Today we're going to be talking about different types of spinal disorders. So first we're going to talk a little bit about the spinal cord in general, or the spine in general. So first you can see you have the brainstem that connects to the spinal cord, and the spinal cord is connected by the vertebra. So the spinal cord is a rope-like, and it has two main functions. Two main functions of the spinal cord is to carry information, and it helps coordinate reflexes. So if you look over here where it breaks down the spinal cord a little better, you can see where you have a disc, and a disc helps with that shock absorption. The vertebra is what protects the spinal cord. And if you look down, it talks about you have your sensory and motor nerve pathways. So you have a small side and a big side. So if you remember, one is sensory and one is motion. If you remember big motions, it is the gray part that is larger. That is where your motor neurons come from. So if you're looking at the spinal cord, you see the small, that is your sensory, and you have the large, which is your motor. The difference you have here is you have a white and gray matter. The white is myelinated axons, which gives it that white appearance, and the main function is communication. Then you have your gray matter, which is the unmyelinated axons. It gives it that gray appearance, and the main function is to unify separate things. So it makes those connections, so it allows the sensory to connect with those motor neurons. First, we're going to talk about general spinal cord injuries. This is a damage to the nerve fibers, and it interferes with communication between the brain and the body. This is a disruption in the nervous system function, which may result in complete or incomplete loss of your motor and sensory functions. The injuries described are described by the location or the degree of the damage. So complete means that there are no motor or sensory function below the level of injury. And then you can have an incomplete spinal cord injury. So an incomplete spinal cord injury, which means they have some function below the level of the injury. Damage can be from a contusion to a complete transection. There can be permanent impairment, but however, that cannot be determined until the spinal cord edema has subsided, which this could take a week. So we don't know sometimes the ending damage until that spinal cord edema has gone down. The most common is your cervical and lumbar because they are the most movable parts of the spinal cord. Most common causes of spinal cord injury are motor vehicle accidents, followed by violence such as assaults, and then falls and sport injuries. So females are more likely to result from a fall, while males are more likely to have acts of violence or sport injuries. A major complication of spinal cord injury is spinal shock, or areflexia. This is a result of the sympathetic nervous system disruption. With this, your client's going to have vasodilation, which results in hypotension, bradycardia, pyrokilothermia, which is the body is the same temperature as the room. So your body temperature is room temperature. They can also have urine and feces retention. This profound effect disrupts your sympathetic nervous system. This is usually seen within 30 to 60 minutes from injury. And this occurs below your cord function. So the cord function below the injury stops functioning. This can last weeks or months. Some other complications we could possibly see would be pressure ulcers from lack of movement, respiratory infections. That's going to depend on where the spinal cord injury occurred. Do they have to have or are they intubated? So is there something that could possibly leading to that respiratory infection? Your DVTs, that's due to lack of motion. Orthohypertension, this is because the muscles in the legs no longer help return blood to the heart. You could have skin breakdown, which is related to that decreased movement. Renal or bowel complications because they don't have that sensation. And then depression and substance abuse. We need to look for those. And then the last one is your autonomic dysreflexia or hyperreflexia. With this one, this is a life-threatening complication that can occur after spinal shock. So it's going to have somewhat of the opposite as far as your hypertension. This can get severe hypertensions and it can reach into the 300s. They can also have a slow heart rate, a pounding headache, complaint of nausea, blurred vision. Their skin will be flushed and sweating. You will notice goosebumps, nasal stuffiness, and they can be anxious. A neurological assessment is what's going to be utilized to reveal the level of the spinal cord damage. However, some diagnostics such as your X-ray, CT, MRI, they can show fractures, compression, edema, or if they are having a hematoma involved. Some things we want to watch for, especially is the respiratory. Anything above C4 will have some degree of respiratory issues and may need to be on ventilation. So with these patients, we want to make sure that we are most definitely watching their respiratory status. If their diaphragm is paralyzed, the intercostal muscles become important because they have to take over. These muscles can become very weak, which can also cause a decrease in the patient's respiratory status. Immobilization, we need to make sure that we are rolling the patient. We need to make sure if they're monitoring any kind of traction or halo braces, which we will talk about, halo vest and different things with tractions in just a little while. We also want to make sure that GI, if they have absent bowel sounds, which are common, we need to make sure we're not giving them any food until you can hear active bowel sounds again. We also may need to place a catheter to make sure the patient doesn't get a distended bladder and to protect the skin from incontinence. Biggest thing with surgery or spinal injury is we're going to stabilize the spine. This can be done by cast, braces, or tractions. The goal is to stabilize the bony elements of the spine and to relieve pressure on the spinal cord. A halo vest device and tractions are usually more used for your cervical spine, while the cast and braces are used for the thoracic or lumbar. Some halo vest management, you want to make sure that you educate the patient on turning their whole body rather than just trying to turn their head. This means that they are unable to drive. They need to make sure they're walking only on level surfaces until they become more accustomed to the vest. That means they need to avoid stairs, curves, uneven terrains. They need to make sure they take care getting in and out of vehicles to avoid bumping the halo or loosening any of the pins. They can use a mirror to inspect the pin sites or have someone, if they're living with someone, help them watch it. We need to make sure that they are cleaning their pin sites 2 to 3 times a day. And this is done with cotton-tipped applicators saturated in oxygen peroxide. Use a clean applicator after making a full circle around the pin site, so make sure we're only using each cotton swab once. We need to make sure that we're clipping hair that grows around the pin sites. Make sure they understand to report any pain or redness or damage at the pin sites. They also need to make sure we're reporting any fever or neck tingling. They need to make sure that they are never to independently adjust the vest. They need to consult the physician. They can pad the vest if it causes pressure or friction. When they have this vest on, they need to make sure they're taking sponge baths. They may use dry shampoo, but they need to talk to the physician about getting the hair wet. They can use pillows for support and comfort when sleeping, and then to make sure that they are wearing loose-fitting clothes with wide necklines. They also need to make sure they're wearing shoes with flat heels and that are easy to slip on and off. Next, we're going to talk about spinal nerve root compression. There are two basic types: intramedullary, which is lesions that involve the spinal cord, and tramedullary lesions that involve the tissue surrounding the spinal cord. Most common area are the three lower lumbars. However, this can happen anywhere. Nerve compression can be caused by tumors, trauma, poor body mechanics, and even age. The most common that we see are your herniated disc or the slip disc, which is when the nucleus within the disc protrudes from the center, as you can see over there on the picture, and then it puts pressure on that nerve root. Some common diagnostics are your MRI, myelogram, and a CT scan. An MRI is usually the tool of choice. If they have had surgery in a suspected area, they will do a MRI with and without contrast. If they can't do an MRI, however, the next option would be the myelogram. Your signs and symptoms are going to depend on the location, as y'all can read through those. Going down the lumbar is the most common, and that low back pain radiating down the leg is usually an indication that the sciatic nerve is involved. Different treatments would be rest and immobilization. We're going to have them rest to have bed rest, and we want them to rest on a firm mattress. We want to try to have them immobilize. They can have PT, which can help regain any kind of muscle strength, and it can also help them educate on proper use of body mechanics. Traction, when we're looking at traction, there is a prescribed amount of weight that the physician will order. When we walk into the room, we want to make sure that the weights are hanging freely. The weights should not be sitting on the floor. They should be freely hanging. And we also want to make sure the client is in line with the traction apparatus. They should not be turned sideways from the traction. They have to be in line with the traction. Some medication would be some muscle relaxers, your NSAIDs. They can also offer epidural injections, and some alternative therapies. You can apply hot moist packs, which helps with your muscle spasms. Some different types of surgeries would be your laminectomy, which is a surgical operation to remove the back of one or more of the vertebrae, usually to give access to the spinal cord or to relieve pressure on the nerves. You can also do a discectomy, which removes the entire disc. And a spinal infusion uses a bone graft to fuse two or more vertebrae together in the areas that are unstable. Pre-op, we're going to make sure we are log rolling these patients to make sure we're not causing any more spinal damage. If possible, we can orient the patient to the floor in which they would be coming to, and we want to make sure that their expectation of pain. Now, pain won't necessarily disappear, but the pain should get better. Post-operatively, we're going to make sure we're monitor for changes in their circulation, movement, checking their sensation. We're going to monitor their color, warmth, and we're going to check their pulses. We're going to monitor pain, and we're also going to monitor the dressing and the drainage that's on the dressing. We're going to monitor any I&Os. We're going to continue to log row them, and we want to make sure, especially if they have traction, to keep them midline. Patient education would be proper body mechanics. It is easy to practice good body mechanics when you follow 3 simple guidelines. The 3 simple guidelines are to stand with your feet apart to create a sturdy foundation. We want to make sure that we're teaching them to bend at their knees instead of their waist. And the third one is to keep their neck, back, hips, and feet aligned when you move. This means they need to avoid twisting and bending at the waist.